Сергей Константинович, меня слышно? Не скажете?
Да, все в порядке.
Я просто смотрю, картинка идет, думаю, тишина, может, что-нибудь выключилось.
Нет, это сейчас будет.
Нет, это у нас просто эфир запущен.
Да,
и мы скажем, когда.
Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования.
Андрей Олегович, вас слышно. Андрей Олегович, вас слышно.
Все, хорошо.
Так, у нас...
Good morning, dear colleagues. Warm welcome to all those who joined the Congress of the Eurasian Association of Therapists, we general practitioners. We are going to convey a broad range of topics, and they are being conveyed during this event. Every symposium, every event is of great interest for sure. Today we're going to talk about the antibiotic therapy in modern realia. Of course, the COVID-19 pandemic has introduced its changes, both in the algorithms of administering the antibacterial drugs, and it has significantly increased the scale of antibiotic resistance as an issue. Besides, the use of antibacterial drugs in special groups of patients has become even more topical among special groups of the patients. So these issues, as stated in our agenda, will be discussed today. So without any further ado, I suggest us to begin. My only request to the speakers is please do not exceed your agenda at the time you have been given. You have 15 to 17 minutes for your presentation. In this way, we will have a Q&A session as well. So the presentation is about antimicrobial resistance in COVID, experience of Komunarka, presentation delivered by Andrei Bykov, Second Medical University and Hospital number 40, Moscow. Good morning, dear colleagues. Thank you very much, Sergei Konstantinovich, for your kind presentation. And because of the shortage of time, let me proceed to my presentation. I'll remind you what antimicrobial resistance is, and then I will tell you about our experience during pandemics. No conflict of interest whatsoever. One of the first, and I would say the first persons to speak about antimicrobial resistance was Alexander Fleming in 1945 when he was given the Nobel Prize. In his speech, he said that the use of penicillin may lead to an immense growth of resistance and inefficiency of antimicrobial therapy. More than 75 years later, today we have convincing range of data witnessing to it, and many of you have read this article, and it says that if no measures are undertaken, by 2050, we may have more than 2.8 million deaths because of the resistance to strains. Since I'm representing the Second Medical University and my specialty is anesthesiology and resuscitation, I will speak about antimicrobial resistance in intense therapy. Why? Because intense therapy is always a high-risk area. The reason is we have a close contact between patient and physician in intense care unit. Our patients are really severe. They have septic shock, the majority of them. Very often we are giving massive antimicrobial therapy to our patients, and they don't really need it. 100% of the patients in intense care unit have implanted devices, tubes, catheters, venous grafts, etc. And of course, it's important to speak about transition of a patient from one hospital to another. All these factors, even 10 years ago, when we had potential magic bullets like carbapenem, today antimicrobial therapy administration by a physician is a really strict approach that requires some knowledge and competence. We can't say today that we can administer antimicrobial therapy without knowing the main inflammators. We have to know in this way or another the main mechanisms of protection, to be aware of the right use of antibiotics. And of course, we need to know pharmacokinetics and FD of the antimicrobial drugs. Today, all this is getting more and more important because we have early diagnostic methods, and therefore we can use an early target antimicrobial therapy. If previously we were doing our first steps in this area, today we have a range of tools. I will tell you about them later, and we can use them. And so within an hour or an hour and a half, we can administer target antimicrobial therapy. Of course, a physician needs many other competencies. Let's now talk about the main inflammators. In 2009, an article was published in the Society of Infectious Disease. They were talking about a number of escape pathogens. It's a structure that causes a large number of nosocomial infections. And these infections are causing a largely lethal outcome in the hospitals among the patients. In 2000, from 2009 to 2015, we were using more and more antimicrobial drugs, new groups, various combinations. The resistance was growing. And unfortunately, it led to a situation when we had to revise the main pathogens. And in 2019, they introduced the notion of escape, and in this abbreviation they added, instead of Enterobacter and Klebsiella pneumoniae, that we have a separate group of Enterobacterialis. It was renamed into Enterobacteriaceae, and Pasteurizum difficilia was added. And today it's getting more and more relevance. At least we see it on the example of our clinic and in intensive care units of Moscow in particular. In 2017, the WHO embarked on the problem. The big review and a big analysis, and the list of pathogens was divided into priority groups. And the first category of critically high level included the well-known dominating microbes in intensive care units. It's the carbapenem-resistant Acinetobacter baumannii, Pseudomonas aeruginosa, and of course, Enterobacterialis family of bacteria, and among them, the most frequent pathogens are Proteus, Escherichia coli, and Klebsiella pneumoniae. Klebsiella pneumoniae being the leading bacteria. This is the data of ITSA, September 2020, a publication talking about antimicrobial resistance gram-negative infections. And this is of interest for us as well, because the most frequent bacteria, pathogens, are Enterobacterialis. There are carbapenem-resistant Enterobacterialis and also Aeruginosa pseudomonas, the most resistant bacteria to carbapenem. As for Russia, we have a wonderful resource. It's an AMR map in our country where the strains are collected. You can see the proliferation of various bacteria in the regions. You can see here the breakdown from all the units of intensive care and therapeutic and surgical units. And you can see that, of course, the dominating bacteria are Enterobacterialis in intensive care units. This is something we were talking about previously. This is a wonderful study conducted by Yakovlev, Suvorov. It's a well-known Ergini study showing that gram-negative bacteria are dominating in intensive care units over 55%. So speaking about the nosocomial infections, we have to keep in mind the gram-negative bacteria. First of all, Enterobacterialis, 40% out of them. This is one of our studies that we conducted. It's a retrospective analysis that covers years 2003 to 2018 in one of the Moscow clinics. Over this period, we had the growth of resistance of various strains to various drugs. So, of course, here you can see a saddening picture. Cephalosporin resistance Klebsiella pneumonia, the gray bar curve, shows you that 100% are resistant strains. As for carbapenem-resistant enterobacteria, Klebsiella pneumonia, from 2011, when there was a booming use of carbapenems, we could see the growth of resistance. And so these microorganisms acquired the genes of resistance. I will tell you later about it. A bit simple with Aeruginosa pseudomonas, and a very sad picture, a very sad situation is with the resistance of, I would say, pan-resistance, Cinnobacter baumannii, to all groups of antimicrobial drugs. This is a huge challenge today among our patients in intensive care units. So briefly about the protective mechanisms of microorganisms, because if we don't know the resistant mechanisms, we don't know how to beat them. This is a funny picture to illustrate the antimicrobial therapy when we don't know what to administer, who to administer, and how to administer. Very much resembling antimicrobial therapy. The main mechanisms of resistance, 4 of them, is the change of penetrability of microbial cell, modification of target, firm enzyme inactivation, one of the most popular mechanisms of resistance, and efflux mechanism that is deploying some types of pumps, and they are spitting out the molecules of antibiotics from the cell. And of course, the resistance can be transmitted in several ways. Vertical, horizontal, and enterobacteries have a more typical plasmatic way of transmission. One of the most proliferated mechanisms is the enzyme inactivation, when the cellular wall produces some types of enzymes that destroy the antimicrobial molecules. And of course, from the moment of detection of this mechanism several decades ago, there were multiple attempts to systematize it. And Andler suggested molecular class by Ambler, named after the scientist. And if we disregard the functional groups that have already been slightly modified by Busham and Jacobi, today you can say that we have the serum enzymes, beta-lactamase, and we have serine in the active centers of them, and also the group of metal enzymes, beta-lactamase, that define the resistance to all groups of drugs. In the active center, these molecules contain the molecules of zinc, and I will tell you later about it. So we talk little about it, but since today we're going to speak about the tools that we can use as we administer early antimicrobial therapy, we should be aware that there exist various carbapenemases, and let's try and remember them for further use in the future. Carbapenemas FA grade. These are the carbapenemas of serial types of beta-lactamases. They can be transmitted both in chromosomal and plasmid pathways. If we're talking about chromosomal pathway, it makes no sense for us because these are sporadic outbursts of no danger. As for plasmid-coded carbapenemas, they are proliferated all over the world, in particular in Russia as well. KPC, Klebsiella pneumonia carbapenemas, is one of the most proliferated carbapenemas types. It's Klebsiella pneumonia, but it's detected elsewhere in other gram-negative microorganisms. So the pathway is plasmids. It was first detected in 1996 in the USA, and it happened so that over the last 20 years, it got spread worldwide. Hydrolytic activity is enlisted on the slide, and of course, carbapenemas KPC defines some resistance of strains to carbapenems. And as a rule, we don't get one KPC, but a constellation of particular enzymes. I will talk about them later. The largest class of carbapenemas is the D class. It's an oxysilane hydrolyzing enzymes, the largest class. Out of them, there are various groups, OXA23-like, OXA40, 51-like. As for better bacteria, it's the KPC. The most popular enzyme there is OXA48-like. And of course, since this is a plasmide pathway of transmission, you can see it in other enterobacteria as well. So why should we know about these carbapenemas, OXA48-like? The modern methods of detection gives us an opportunity of an early target microbial therapy. If we know what is the determinant resistance, as we do the PCR test, we know the target and we know how to affect it. This started in Turkey, in one of the university clinics of Istanbul. There was a patient with burning traumas, and he had carbapenemas detected, and it got spread worldwide. And I would say the most threatening type is the carbapenemas of metal enzymes of B class, and they cause resistance towards almost all groups of drugs. Of course, there are some therapeutic options to overcome resistance. However, their efficacy is getting weaker and weaker. A few words about modern tools that I mentioned in the beginning. Of course, the competences of a physician should include today the state-of-the-art methods of early diagnostics in intensive care units. Is extremely important, because the earlier we administer to a patient with septic shock the accurate targeted therapy, the higher the chance of survival is. And of course, not all of the state-of-the-art tools make it possible to define carbapenem resistance, including the definition of metal beta lactamase. And of course, because of the limited period of time, it's impossible to enumerate all of them. I'll speak only about two methods. One is the modified method of carbapenem inactivation, which today can be used in all bacteriological laboratories. And all bacteriologists are mastering this method very well. Within 8-12 hours, it is easy to define both the production of carbapenemas and the possibility of using the test. And of course, define the metal beta lactamase. And therefore, one can adjust the corrective therapy. As for our clinic, apart from PCR tests, we have an option of using early detection based on the cartridge diagnostic method. And it helps us in the nearest future to detecting the native material, the gene of resistance, which helps us within the minimum period of time, in 1 hour or so, to get some determinants of resistance and adjust for our septic shock patients the targeted therapy, which is possible out of the entire range of resistance that we have. On this slide, you can see some combinations, the most frequent combinations among our patients. And if a few years ago, when Sergei Vladimirovich Sidorenko was saying that the gene resistance, KPC and NDM are proliferated in St. Petersburg, today we are bringing an example of a city clinic that is working for more than a year. And we are jokingly calling it 3-in-1. When we encounter among our patients in the native material the combination of metal beta lactamase in combination with 2 serial carbapenemas, in particular KPC, OXA48-like, of course, we have less and less therapeutic options to treat them. So I would say this is a good way. and a possibility of doing early diagnostics and correction of antimicrobial therapy. This is a live example of the data we got over the time. And as I represent my clinic, I want to say that this is quite a large hospital, more than 1,800 beds with intense care unit, 400 resuscitation beds. Big experience, as you may guess. And as for dynamic resistance, in all departments of our clinic, from the month of April 2020 to June 2021, one can observe the growing resistance of gram-negative bacteria because of carbapenemas producing enzymes. As for the dynamics and frequency of resistance to carbapenem, as you can see on the slide, it amounts to 97%, so the failure rate is really high. As for the spread of molecular types of carbapenemas, the data is sad indeed. Today, we more and more get the constellation of not one enzyme, but also severe combination of 2-3 carbapenemases, including beta-lactamase. As I finish my presentation, I want to say, what can we do? You know that the WHO and all the AMR dealing organizations have developed their plan, and Russia also has an AMR strategy. And I do advise you to familiarize yourselves with it. It describes it all, how to deal, what to do, how to go hand in hand and beat antimicrobial resistance in the Russian Federation, because one day the pandemic will be over, but the resistance will remain forever. Thank you so much for your attention. I hope you found this presentation useful. If you have questions, I'm ready to take them. Thank you very much, Andrei Olegovich, for an extremely interesting and important talk. Colleagues, we should be well aware that what Dr. Bykov was telling us now, it's not a situation typical for intense care units only. We need to understand that all those mechanisms of resistance that were discussed in every detail now, after all, are going out of the clinics. The mechanism of transition are plasmids, and unfortunately, my biggest concern is that in the nearest future, we will face a situation of an extremely broad proliferation of AMR out of the hospitals. Unfortunately, AMR led to a situation when we have now a big wave, a soaring wave of antibiotical resistance. And it will continue in the outpatient conditions as well. Thank you so much, Andrei Olegovich. If there are questions, we'll be happy to take them. I hope very much that we will have enough time for a discussion. And now we go to the next presentation. We'll be speaking about using antibacterial drugs in pregnancy. Professor Yelena Andreevna Ushkalova has been dealing with this topic for quite a long time, and the floor is yours, Yelena Andreevna. Good morning. Hello, good afternoon, dear colleagues. Well, from the quote that you see on my slide, you may guess that unfortunately both pregnant women and their babies are the orphan groups of the population in what concerns the safety and efficacy of drugs. And unfortunately, my presentation is but a confirmation of this quote. Meanwhile, the use of drugs during pregnancy, including the antimicrobial drugs, has increased significantly. And according to the WHO, about 90% of women are taking drugs during pregnancy, and there's similar data in Russia as well, both based on the studies conducted that are unfortunately not so numerous and based on the official statistics. Moreover, please note that during pregnancy, almost every woman, well, maybe not at a time, but nevertheless, she takes from 3 to 8 drugs. And this makes it even more difficult to study the efficacy and safety of drugs, both from the perspective of drug-to-drug interaction and in general. And as a result, the potential consequences of using drugs during pregnancy include, unfortunately, a lot of extremely negative consequences for the mother and the fetus. And most often, both the physicians and the patients are more concerned about the congenital anomalies in the fetus as a result of drug therapy. And they pay much less attention to a potential inefficacy of drug therapy, including antimicrobial therapy, which leads to which brings some consequences not only for the patient and the fetus, but also for the population in general. And this is something the previous speaker was mentioning. Because as we administer drugs, including antibiotics during pregnancy, the physicians are extrapolating the data that they get from the studies of not the pregnant women, but males, because until now, males were more frequently included in the clinical studies than females. And yet, unfortunately, pregnancy is a period when pharmacokinetics is being greatly transformed. And this requires a really specific approach with the consideration of many, many factors. At the moment, the problem becomes even more difficult because the achievements of medicine allow women to give birth at the age that was previously simply impossible. I would say that pregnant women are aging. The mean age of first pregnancy in Russia, 27 years old. When I was a student, this age was considered to be an old age for a future mother. In turquoise color, you see another factor, and I made sure about it myself when I was working in our Center of Gynecology and Obstetrics. We have a lot of women who give birth at the age above 50 years old. And please note that in 2019, 5 Russian women were above 60 years old when they gave birth to children. That is to say, we even have geriatric patients. The pharmacokinetics during pregnancy is then overlaid by the challenge of pharmacokinetics of elderly people, because they are also undergoing big transformations. These are the parameters that affect the change of pharmacokinetics during pregnancy. You can see it on this slide. And first of all, I would say that it is the development of placenta that otherwise is not present in the human body, and also the presence of the uteroplacentary vascularization lead to a situation when the distribution of drugs becomes so different, and in different periods of pregnancy, it is changed differently. It can be both the increase of body mass during pregnancy, and also lipophilic drugs may be accumulated, and so on and so forth. there is another, I would say, a special challenge that gains more and more attention, is the change of metabolism during pregnancy. First of all, the activity of cytochrome enzymes CYP450 and a number of other enzymes. In this way, during pregnancy, it is both the distribution and the metabolism are compromised. Secretion is increased. Besides, there's also an interaction happening between the mother and the fetus. You add the transport on the placentary level to this, metabolism on the placentary level, and metabolism in the fetal body. Some other factors that may impact the pharmacokinetics during pregnancy is the multifetal pregnancy. Of course, the social factors are of great importance, and unfortunately they are but increasing. It's smoking, alcohol, drug consumption, etc. Besides, very little researched are the racial and ethnic factors that are actually playing a great role both during pregnancy and before and after. And during pregnancy, I would say they become even more relevant. And taking into account that women are getting pregnant later and later, after 40, after 50, and even by the age of 60, we have a growing number of women, pregnant women who suffer from chronic diseases, and this may lead to the changing pharmacokinetics. And so plus the doctors are very cautious about pregnant women, and usually the doctors are trying to avoid pregnant women. They try to refer them to other specialties, and when there's a polymorbidity, a doctor thinks that he needs to administer some drugs, and so polypragmasia leads to some serious pharmacokinetic interaction, and the outcome of pregnancy is very hard to predict. As I've already said, the specifics of metabolism is a big challenge, and you can see that the activity of various enzymes is changing throughout pregnancy. And these kind of enzymes, in fact, are numerous. More than 20 groups of these enzymes are highlighted. The most important ones out of them are 3A4 and ED6. You can see the results of 2 studies here. Up to 50% of drugs that are subject to metabolism are metabolized with the involvement of the isoenzyme 3A4, and a bit less is involving 2D6. But unfortunately, 2D6 has another property. And of course, depending on the speed of metabolization, we can divide the patients into 4 groups, so on and so forth. And there are some results of studies that prove how the clearance of drugs is changed throughout pregnancy. I think the practical relevance of clearance of caffeine, the clearance of caffeine is reduced by 60% during pregnancy. 3A4, the variable changes depending on a drug and specifics of particular patients are there. You can see that the activity of other enzymes involved in metabolism is changed too. And you can see that the women having various monotherapies or polytherapies have different responses to it. Well, as we speak about antibiotics, so we are mainly speaking about the changes of creatinine clearance, relevant creatinine clearance throughout all trimesters of pregnancy. I would say that a study published, a systemic overview published in 2005 shows that despite a broad use of antibiotics to treat the mother and to prevent congenital infections in fetus, only 24 studies are dedicated to the study of pharmacokinetics of antibiotics among pregnant women, and most of them are inadequate from the perspective of design, number of patients, and most importantly, none of them assessed the dependence of pharmacokinetics and efficacy of drugs. Moreover, for those isoenzymes that are subject to polymorphism, they try to develop the guidelines for them. You can see the guidelines for the serotonin selective inhibitors of reverse capture. And I would say the main trend here is the slow metabolizers are drawing most of the attention, or it is the possibility of using them with other drugs or to reduce the dosage. Nevertheless, both the guidelines and some others that analyze these guidelines indicate that we don't know how well they can be used in practice, but the fact that a physician should consider the practical use of drugs, well, first of all, he has to consider the physical and chemical properties of drugs. Preferably, he should use the drugs with high molecular mass. However, not all of them are overcoming the placentary barrier. Besides, the time of penetration and stay of the drugs is highly dependent on the duration of the metabolization. So, if possible, the physicians should select the drugs with a shorter period of metabolization. It should be considered that the penetration through placenta is increasing over the course of pregnancy, and the assumption that pregnant women have to take the minimal therapeutic dose of a drug is very often perceived that they need to take the minimum targeted dose. But in fact, the minimal dose during pregnancy may increase the average therapeutic dose, especially towards the end of the pregnancy. And of course, if possible, we need to give a combined therapy. The problem is getting more difficult because a new organ is developed, placenta, the waters, and all these compartments may accumulate the drug. Moreover, placenta contains a lot of enzymes, as you see, and the activity of these enzymes is changing all the time. Moreover, the placenta expresses a lot of transmitting proteins, and their activity is highly dependent on the month of pregnancy. And it was shown that before the childbirth in normal pregnancy, the level is going down in placenta. And so a woman is more sensitive to a number of drugs that during this time are very often administered. Moreover, the levels of these transmitters are changing in pregnancy pathologies. Moreover, it should be considered that only the drugs that are non-binded and free are penetrating placenta. Moreover, the penetrability of placenta is increasing towards the end of pregnancy, and it may change under the impact of other concomitant drugs. And as the urinary system is changing in the fetus, the metabolization is changing too. The pharmacokinetics of the fetus is extremely variable and is dependent on the term of pregnancy, because the composition of the body is significantly changing, and most importantly, the activity of enzymes is changing. Some fetuses, and please take a look. We have a limited number of drugs with a changed pharmacokinetics. For example, deltaparin. Look at how it's changing in comparison with the pre-pregnancy level in the third trimester. Of course, we need to monitor it. And of course, the response to treatment should be monitored as well, and some other laboratory parameters too. Unfortunately, regarding the guidelines of today in what concerns the administration of drugs and the change of their dosage during pregnancy, it's almost impossible. So this matter requires a thorough study. The medical community is urging for a long time to do the studies of drugs with the involvement of pregnant women, because it's not ethical to extrapolate on pregnant women the data that we got on the non-pregnant subjects and males. Of course, an important factor is pharmacovigilance. And so before the suggested studies of pregnant women, it is proposed to do this type of modeling, starting from in vitro studies and extrapolation of results. And of course, this topic can become really important for many scientific theses. But you can see more details if you follow the link that you show on the slide, shown on the slide. Thank you so much for your attention. Thank you very much, Elena Andreevna. It's a global challenge indeed, the use of drugs during pregnancy. Despite a special attitude to a woman in this very particular period, we, of course, need to keep in mind that in case of any disease, including infectious disease, a woman should get an adequate therapy. How to select the drugs and the doses, these are the matters that require additional discussion and most thorough attention of a practitioner. And of course, we can't use any standard approach here. Every time the situation is very individual, depending on the pregnancy, condition of the woman, etc. And of course, this matter requires additional elaboration. I will be happy to take your questions. We will be happy to take your questions if there are any. And Yelena Andreevna is staying with us. Thank you very much again, Yelena Andreevna. And we're going to a very important topic. What to do if the patient has a certain stage of kidney disease? What do we do if the liver function of a patient is changed? How to select the product and how to dose it accurately? Olga Butranova from the Russian University of People's Friendship. Good morning, Olga Viktorovna. Good morning. Can you hear me? Yes, please share your screen. Can you see my presentation, colleagues? Yes, we can see it. You can start. Okay, I'm getting started. We'll speak about the patients with the changed kidney and liver function, renal function. When it's changed, it can be the result of critical conditions. It can affect the special categories of patients, and also it can indicate a chronic pathology of kidneys. So the changed renal function. The above-mentioned factors are impacting the pharmacokinetics of drugs, and the changed pharmacokinetics results in a changed pharmacodynamics, which in its turn may deteriorate the initial condition of the patient. The changed renal function can be either compromised or elevated. Let's first of all speak about the compromised function. Physiological and pathological factors may lead to the compromise of renal function. The compromised renal function in its turn will contribute to the reduction of the drug elimination, and as a result, it will prolong metabolization. For the drugs that work through kidneys, this can be extremely important, and it may affect safety and efficacy. As for the improvement of the renal function, one of the physiological factors is pregnancy. Critical conditions, including trauma, burns, severe infections, and sepsis. As an increased kidney clearance is the creatinine clearance more than 30. On this slide, you can see the specifics of pathogenesis of the creatinine clearance elevation with some critical conditions. So what will an elevated creatinine clearance lead to? In this case, the level of elimination of drugs will be increasing, and this will increase the period of half-life and the concentration of drug in the blood plasma. This will elevate the efficacy of drug because and this may require the increased dose of the drug. Here are the examples of the drugs that are relevant in this case: vancomycin, beta-lactams, aminoglycoside antibiotics. Considering state-of-the-art epidemiology, we have to mention the problems of patients with COVID-19 and compromise of renal function. we can see here an acute kidney failure in the patients with COVID-19. In red, you can see the most relevant studies that involved a number of patients, over 4,000 people. The CKD, according to the study, was less than 1/10. Nevertheless, a number of other researchers it's 20 to 40. In some cases, the CKD is you can see the relevant results highlighted in red, two important parameters here, 10.5% and 17%. According to a large study that we conducted in the clinical hospital number 24, it involved the patients with confirmed COVID-19, severe pneumonia, and also positive growth in the bacterial media. The number was 200. The share of patients with acute kidney failure was almost 29%. Another selection are the patients that we collected the information about in clinical hospital 24, the patients with confirmed COVID-19 and confirmed lethal outcome, severe pneumonia, total number 410 patients, period from 1st of March to 14th of April. Among them, the patients with acute renal failure was above 60%. As for the international data and systematic reviews and meta-analysis involved more than 4,000 patients. Out of them, 212 had chronic kidney failure. So patients with severe COVID-19, 4.5% had chronic kidney disease. As for the chance ratio, it shows a high result, 2.15. Among the patients with lethal outcome caused by COVID-19, chronic kidney failure was 19%. Patients with CKD had an increased risk of death in comparison with patients with no pathology of this kind. Another systemic overview and meta-analysis that involved a much greater number of patients, almost 14,000 patients, showed that 11% of the patients with COVID-19 had the acute renal failure developed, which had a correlation with severe course of COVID-19. The correlation was 8.45. Also, CKD was associated with a higher chance of lethal outcome caused by COVID-19. All in all, on this slide, you can see the specifics of pathogenesis of acute renal failure caused by COVID-19 and respective infection. The viral myocarditis, rash, and loss of hydration launch a synthesis of a large number of pro-inflammatory substances with the activation of CD8 plus, CD4 plus cells. This leads to antigen-specific B cells development of antibody, and it damages the kidney tissue. So, what are the specifics of dosages of drugs among the patients with renal pathology? We all know that the basis of drug dose calculation includes the formula that you see on this slide. The most important ones are the glomerular infiltration rate and creatinine clearance. The patients who get substitutive renal therapy, among these patients, the dosages of antibacterial drugs are extremely important. What are the factors that we need to consider? First of all, it's the volume of distribution, binding with plasma proteins, and molecular mass of drugs. These factors impact the degree of extracorporeal washout of the drugs in dialysis. So this underpins the distribution volume for the patients in critical condition of such antibiotics as aminoglycosides, beta-lactams, vancomycin that may increase up to 100% in comparison with healthy subjects. As a result, there's a risk of insufficient loading dose, which underpins a more aggressive approach to achieve a therapeutic effect. The drugs that are described by the volume of distribution more than 2 liters per kilogram are envisaging the distribution of drug in both extravascular compartment and or significant binding with the tissues. And here we can recommend an intermittent hemodialysis and a temporary reduction of drug in plasma that can then be combined with further rapid growth of concentration. In case we have a V approximately 1 liter per kilogram, then the drug absorption in blood will significantly grow. The clearance parameters with the patients on substitutional therapy, the total sum of clearance and the half-life extraction, to all this we need to add extracorporeal clearance. With renal substitution therapy, as a rule, the non-binded fraction of drugs is removed, so ultrafiltrates will be correlated with them. The molecular mass is one of the crucial factors here. For the majority of antibiotics is more than 1,000 delts, and it's usually proportional to the molecular mass. As for the membranes of dialyzers, the low penetration membranes of clearance drugs of molecular weight more than 1,000 delta can be clinically irrelevant. In high penetration membranes, we will see an active removal of the drugs with molecular mass more than 1,000 Dave. So dialysis may reduce the concentration of drugs in plasma to the less than therapeutic level. Another special thing is the albumin forms on the membrane. On one hand, of course, they facilitate the transport of drugs like cephalosporin. On the other hand, it makes it difficult for aminoglycosides to penetrate. The water-soluble antibiotics are metabolized through kidneys, beta-lactams and aminoglycosides. So the level of elimination in dialysis is increasing, so we need to thoroughly adjust the dose. The lipophilic antibiotics, in their case, the elimination is rapidly reduced in dialysis, so we don't need to adjust the dose. The positive, we have two pharmacokinetic phases, intradialysis phase. The high speed of elimination will lead to the reduced half-life, and interdialysis phase will lead to the increased period of half-life. As a result, the start of dialysis is recommended in the end of the interval of drug dosage. On this slide, you can see the relevance of various antimicrobial drugs and their extracorporeal fraction clearance with renal therapy. In red, you can see the drugs that in the lion's share of cases will be significantly removed. The dosing of various groups of antibiotics among the patients with on renal therapy. Aminoglycosides are recommended to be taken once daily before dialysis. And of course, the monitoring is of must. Beta-lactams. The maximum elimination speed is observed for carbapenems. Intravenous infusion is recommended, and also the reduced interval between the doses. Vancomycin The recommended approach is the non-interrupted intravenous infusion with therapeutic monitoring. Linezolid, it is recommended to use the loading dose and an additional dose after dialysis completion. An important parameter in treating the patients with renal pathologies are the prognostic models that can be based on the glomerular filtration rate or on the pharmacokinetic parameters. Why? We need this to potentially select an individual dose for a patient. This is another study that we conducted in Clinical Hospital 24, where we studied the pharmacokinetic and dynamic parameters of neuropenem according to the therapeutic drug monitoring. You can see here the cohort of the patients, and on this slide you can see the ratio of the model predicted changed concentrations of neuropenems in blood. The linear regression for meropenem clearance and creatinine clearance for various diapasons with the values of creatinine among adult patients is shown on the slide. What are the conclusions that we've made in this study? For the patients with creatinine clearance less than 7 liters per hour, the regression ratio of meropenem clearance can be of benefit for the adaptation of meropenem dosage. For the patients with above 7 liters per hour creatinine, there are no proven advantages. What about patients with COVID-19? As we have already said, renal pathologies are quite typical for these patients. On this slide, you can see the most typical doses of the most typical drugs that we use in COVID-19. It's chloroquine, hydroxychloroquine. The dosages need to be modified. For azithromycin, modification is not necessary. As for antiviral drugs, we can see that they didn't require any adjustment of dosage. The same is true for favipiravir. In case of remdesivir, for the patients with creatinine clearance less than 10 and more severe patients on hemodialysis, we do not recommend to use this drug. The liver failure can also impact the decision-making on the dose. What about the compromised liver function? How does it influence the pharmacokinetics? The pharmacokinetic parameters will be transformed in case of liver failure. What about absorption? With the reduced secretion in GIS, the maximum concentration in blood plasma may be reduced. The penetrability of the gastrointestinal tract can give us also a compromise. Reduction of blood flow in liver and free clearance fraction reduction may lead to the elevated liver extraction. With renal function, liver function compromised, the blood pressure in plasma is reduced, and this can negatively impact the hydrophilic drug absorption. The increased concentration will contribute to the volume of distribution of lipophilic drugs. In its turn, what concerns the clearance, the reduced blood flow in liver and in renal fraction will contribute to the reduction of drugs with clearance with high renal extraction. This in its turn can lead to variable changes in the clearance parameter. As for proteins, you can see on this slide the most typical proteins that are ensuring the transport of antibacterial and antiviral drugs. So with renal function compromise, we will be observing the changes of activities of these proteins. This may lead to the changed pharmacokinetics of the drugs, metabolism in liver, both the first non-synthetic phase that is guided by cytochromes. What are the changes? Cmax, the maximum concentration in blood plasma, will be going up, clearance will be going down, and the half-life will be increased. Adaptation of the maintenance dose is considered here for the drugs with the low renal extraction that doesn't alter the pathology, but in some cases can impact the liver clearance. It is recommended to maintain the supporting dose. For the drugs with interim extraction from liver, the starting dose can be low and the maintenance dose must be lower. The concentration-dependent antibiotics among the patients with liver failure. In case of the VD volume increase, we need to have the holding dose and its increase. In case of the liver clearance, we need to reduce the maintenance dose. Time-dependent antibiotics, their efficacy is associated with time when the concentration of non-binded drug is exceeding the MIK in stable condition. The specifics of antibiotic dosage depending on the liver function failure. On this slide, you can see tigecycline and ofloxacin. According to Child-Pugh score A and B classes do not require any adjustment for tigecycline. For C class, we need to reduce the maintenance dose. As for metronidazole, A, B by Child-Pugh don't require adjustment, but they need to be monitored. C, we need to cut the dose half. For clarithromycin, no adjustment is required, and the definitive function factor here is the renal function. Regarding clindamycin, A and B by Child-Pugh do not require any adjustment. Chloramphenicol, they require the mandatory monitoring of the serum concentration. Let me also briefly talk about the parameters of the liver failure among COVID-19 patients. Liver-wise, both hepatocytes and cholangiocytes, we can observe a high concentration of ACE2 receptors. Their activation as they get into as the SARS-CoV-2 virus goes into the body, it leads to the direct failure of cells. With the additional cytokine storm and decompensation of chronic liver diseases, this is observed along with COVID-19. The meta-analysis that we got in 2020 on over 4,000 patients, we observed a significant correlation between liver dysfunction and mortality outcome among COVID-19 patients. We also detected a correlation between AST level and severity of COVID-19. One more meta-analysis over 4,000 patients in this case has demonstrated the overall affection of liver failure of more than 19.5%. And out of 19 cases of mortality, we had the liver failure in 22% of cases. the large meta-analysis that shows you almost 13,000 patients shows 26.5% of patients with acute liver failure in SARS-CoV-19. You can see here the impact of the liver disease on the mortality level in COVID-19. The authors propose the following table, calculating the mortality rate once hospitalized, once admitted to ICU, and once receiving invasive ventilation. So we see that in red color, we have the quadrant of 90% of lethal outcome with the patients who have severe liver failure and the patients that were once receiving invasive ventilation. As for hepatotoxicity of the drugs that are used in COVID-19, in chloroquine, hydroxychloroquine, we see the growth of the transaminase level and acute liver failure. Lopinavir, that's metabolized in liver, has a growth of aminotransferase by 5 times in 3 to 10% of the patients. Ritonavir also had an elevation to 5 times among 15% of the patients. For remdesivir, favipiravir, ALT, AST theoretically will be elevated, but we don't have accurate data. In azithromycin, the asymptomatic elevation is very rare. The high rate can be observed among the patients who were on long-term therapy. As for tocilizumab, up to 40% of the patients have the dosage-dependent elevation of ALT. Hepatocellular failure of liver cells is possible. Sarilumab, it elevates the level of AST. Dear colleagues, thank you very much for your attention. Thank you very much, Olga Igorevna. Thank you for your very thorough presentation. And of course, please remember we need to consider all the patients with organ failures, and you were very concise and comprehensive. Thank you very much. We don't have much time left, colleagues. We need to move on. And here is a question that I wanted to discuss with you. It's the use of antibacterial drugs among elderly patients. It is apparent that the patients of elderly age have a number of concomitant diseases, a whole bunch, I would say, of diseases that they gain throughout life. And an important role in this bunch of pathologies is taken by infections. If we're talking about the extraclinical pneumonia, if we're talking about community-acquired pneumonia, it's 50% in the elderly group of patients, 60 plus. They also have a frequently occurred infections of urinary tract. But most importantly, the infectious process has a very severe course among elderly patients, and the lethal outcome among the patients of elderly and very old age is much higher than the similar statistics of younger groups, because the lethal outcome from the community-acquired pneumonia in younger patients is low, whereas among elderly patients, it may reach to 30–40%. In 50% of nosocomial pneumonia, patients die. In case sepsis develops, 2/3 of the patients have a bad outcome. It is apparent that the choice of antibacterial drug and the accurate dosage are playing an important role in the success of treatment. So let's try to dwell upon these matters and think of the adequate dosage considering the pharmacokinetics and pharmacodynamics that is typical for elderly patients. Let's traditionally start from step 1 of pharmacokinetics. Step 1, absorption. It is apparent that at this stage, we have the change of pharmacokinetic parameters. This is caused by the changed secretion of the gastrointestinal fluids, the changed activity of intestines, and also the ongoing ischemic processes. But please note that these omnidirectional changes in GIS lead to various changes of pharmacokinetics. On one hand, azithromycin with a reduced secretion of salicylic acid gives us a reduction of bioaccessibility, and we will see the same on saxagliptin and in a number of other antiviral and antifungal drugs. On the other hand, we understand that once the absorption associated with reduced prokinetic activity is changed, then in this situation, we may arrive in a result whereby the standard dosage of drug may be inadequate, and so we'll therefore need to increase the dose of the drug. How strange, no matter how strange it sounds, because we are used to saying that because of the slow down secretion, we normally reduce the dosage. Nevertheless, in a number of situations, to achieve an effect, we may need a higher dosage of drug. And of course, it all depends on the conditions and of the systems and organs of our patients. What else is important when we're talking about our patients, elderly patients? We need to think of the form of the drug, because this is something the efficacy of the therapy depends on, and the frequency of MACE depends. We understand that the patients of elderly age and senile age have the most frequent rate of swallowing problems. They have a compromised function of excretory glands, and it turns out that among the patients of elderly and senile age, we have a much more frequent drug esophagitis. When we give tablets and capsules to the patients, we need to keep in mind that these tablets and capsules may for a long time stay in esophagus, and some molecules may cause the ulcerous failure of esophagus. Up to 70% of esophageal ulcers is caused by taking acetocycline. So please keep in mind that if a patient has a failed swallowing function, we need to avoid tablets in those patients, and if possible, we have to use the perioral drug forms that can be dissolved and get the solution to be taken with higher pharmacokinetic advantage. The so-called dispersed tablets are of advantage. We remember that dispersed tablets are about better bioaccessibility, and it's about higher safety for the patients. A number of clinical guidelines in treating community-acquired pneumonia, Chinese clinical guidelines or the WHO guidelines directly imply the need of using the drugs in the form of dispersed tablets. The next step is distribution. It's altered among elderly patients, but on the other hand, we understand that they have a compromise, they have a reduced body mass. On the other hand, the proportion of fat versus muscles may change, and also the intracellular liquid ratio may change. So all these changes will impact differently the dosage of drug. So if we have a higher proportion of fat, we understand that there is a higher distribution, there will be a better distribution of the fat metabolized drugs. So if we disregard this factor, this condition, we may eventually get not only a therapeutic but also a toxic action of a drug. I'm talking about macrolides, fluoroquinolones, and many antifungal drugs from imidazole group, and vice versa. In a number of cases, our patients of elderly and senile age have edemas. And we understand that accumulation of liquid in pleural areas, etc., all this leads to a concentration of hydrophilic drug in plasma and subsequently in the site of infection. It becomes absolutely non-efficient because the amount of liquid is changing. And in this relation, we understand that the dose of drug in a patient with edema has to be adjusted. A hydrophilic drug will go to this edema and the created concentration will not be sufficient. And in this situation, we'll have to speak again about the need of increased dose. And please note that the patients of elderly and senile age do not always require reduced dosages. The problem of metabolism. Of course, the attention to this problem among elderly patients is of great importance. We understand that the enzyme activity is reduced, and on the other hand, our elderly and senile age are also taking other drugs to treat concomitant diseases, which in its turn leads to a competition for metabolism enzymes and the drug-to-drug interaction as well. In particular, this is important to be, and it should be kept in mind in case of NOACs. We remember that drug-to-drug interaction of antimicrobial drugs and warfarin is of great importance, and antibacterial drugs as a consequence of metabolism impact and also intestinal microbiome lead to the prolonged action of warfarin and to the risk of large hemorrhages. And in this sense, the cephalosporin group of antimicrobial drugs and aerosol antifungal drugs are especially potent, while the cytochrome 450 group and macrolide group of drugs, clarithromycin and metroleucin, and perioral anticoagulants, the so-called NOACs, all this is typical for them because the majority of them are metabolized with the involvement of isoenzymes D450. And so if you administer rivaroxaban, evaxaban with the wrong antibiotics and antifungal drugs, may lead to an increase of their concentration in serum, and this will elevate the risk of large hemorrhages. In this way, the knowledge of enzyme systems of metabolism and the understanding of risks of all those interactions that may occur is of extreme importance. We remember that these kind of interactions can be of two types. In one case, one drug may facilitate the metabolism of another drug, and we will have an induction of cytochrome system and reduction of therapeutic effect. On the other hand, we may have a slowdown of activity, inhibition of activity of cytochrome B450, and we eventually will have the toxic concentrations of drug. So look, if we're talking about antibacterial drugs, and I was recollecting them a lot today, and I will remind you about them again now, they significantly impact the activity of cytochromes. By macrolides, antifungal drugs are significantly impacting them. The grapefruit juice is a well-known natural inhibitor of cytochrome B450. So the administration of these drugs with statins and the calcium channel blockers, the frequently deployed drugs among senile patients, may lead to a number of negative reactions. Let me bring you a few clinical examples. Patient with diabetes mellitus type 2 gets perioral therapy. What will happen if with this type of therapy and controlled course of diabetes, you give antimycotic drug? With fluconazole, the concentration with the administration will increase by 48%. What will happen if you will administer fluconazole? It's a very frequent situation. The concentration of glimepiride will increase double the times. The risks of severe hypoglycemia will increase several folds. The same thing can happen among the patients that are taking calcium antagonists. If we are administering macrolide antibiotics, then the risk of hypertension is increasing several folds. Or if the statins are administered with antifungal drugs, the atorvastatin concentration will increase by 40%. And all this elevates the risk of myopathy, myolysis, and also renal failure. In this way, colleagues, it's important to understand that at all stages, not only at elimination that Olga Igorevna mentioned, there takes place a relevant transformation of pharmacokinetics of antimicrobial drugs. All these changes must be considered and not just speak stereotypically about the need of reducing the dosage of the drug because of the relevant, let's say, elderly age of a patient. Thank you so much for your attention, colleagues. We have 1 minute left. Elena Andreevna, if you are with us. There's a question to you about the treatment of asymptomatic bacteriuria. This is a matter that has been debated on for a long time. About 2 years ago, there was a meta-analysis published with the participation of over 2,000 pregnant women. And why is it at all that they recommend to treat this disease? Because it elevates the risk of pyelonephritis and the risk of premature childbirth and low body mass of the child at birth. In meta-analysis, we couldn't get clear data because, as usual, in pregnancy, the level of evidence is unfortunately low. It requires further studies, and the intuition of a doctor has to be there, but also we need to safeguard us from the consequences. Thank you very much, Elena Andreevna. Colleagues, we have depleted our time, and I believe that all the messages today were useful, not only from the perspective of news in the therapy, but also were of practical relevance. And there was valuable advice given on how to increase the efficacy and safety of antimicrobial therapy. I do thank all the speakers, and I do thank all the listeners. Thank you very much. Best regards and goodbye. First of all, I'd like to introduce the Vice President of Russian Osteoporosis Association, PhD in medicine, Professor of Yaroslavl State Medical University, Olga Borisovna Ishova. Good evening, Olga Borisovna. Good evening, colleagues. Good evening, everybody. My pleasure to introduce Doctor of Medicine, Chief Rheumatologist of the Sverdlovsk Oblast Healthcare Ministry, Head of the Oblast Rheumatological Center, Lyudmila Yevsegneva from Yekaterinburg. Good evening. Good evening, everybody. And of course, our well-known endocrinologist from St. Petersburg, from Almazov Center, PhD in medicine, Dr. Tatiana Karonova. Tatiana Karonova will be speaking about vitamin D. Good evening. Good evening, colleagues. Good evening, Olga Mikhailovna. Today, we would like to organize our work in a way that you immediately have questions to ask, and you have this opportunity. Please type your questions in chat. We have allocated time for Q&A session, so please take the opportunity. The co-moderators of this symposium are really well-known Russian experts, and they have this valuable practical and theoretical experience. So do take an advantage and do ask questions. We will take them with pleasure. After an introduction, I guess we can now go to the topic of our symposium. So I'd like to give the floor to Lyudmila Yevsegneva. Your slides, please. The floor is yours, Lyudmila Petrovna. Good evening again. My topic is the compressive fractures of vertebra, the practice of a physician. Let me start from a simple case that we often see in the patients. I say we because rheumatologists often see these patients, and they are referred to us, especially if we are dealing with osteoporosis. This is a female patient, 70 years old, change of posture, back pain. She has dyspnea in physical load. She has limited restricted movements, a history of this back pain several years, change of posture began 2-3 years ago. Please note that in the history of her disease, at 60 years of age, she had a fracture of radial bone. I started from my presentation by saying this is a regular case. So by simply an appearance, I see this patient and I understand that most probably she has a vertebral fracture. Our rheumatologist traveled to the oblast, and he was surprised that he was referred patients with back pain and joint pain who have the back pain for many years, change of posture, but there's never an idea that they may have osteoporosis and vertebral fracture. And it's not always timely that these cases are being diagnosed. We know that the back pain in osteoporosis can be acute at the moment of vertebral fracture, and we see part of these cases. And then it's easier to diagnose osteoporosis because a patient with an acute pain is more likely to go to the doctor. In the night, when there's a chronic pain, there can be several reasons to that. For example, there were compressions of fracture with non-acute pain. New fractures are appearing. The pain becomes chronic and sometimes it amplifies. As a result, the posture is changing. The muscular structures are involved, and this is defining the chronic back pain. The pain can also occur in the lateral parts of abdomen, and it is associated with the iliac bones and fracture of the mid part of vertebra. This is asymptomatic, and the patient may never come to see you, but he can be referred to you because of the change of posture. So do pay attention to it. The posture is changing differently in vertebral fractures. It can be an increased thoracic kyphosis or lordosis, or compensatory increase of lordosis. It can be a total kyphosis, arch-shaped, which includes the thoracic and mid part of vertebral. But it might be an absolutely normal posture, which doesn't exclude vertebral fracture. And so the reason for the examination is the back pain. The quality of life is also compromised. And I wanted to tell you how it reduces when we have a fracture, vertebral fracture, when it happened recently. You can see how quick the deterioration comes within first 2 weeks after vertebral fracture. It can occur just overnight, and the patient comes to the physician, and the physician shows this type of a reduction of the quality of life. But important enough is quality of life is not restored completely. Some restore it, some not. And so the studies that were conducted, long-term follow-up, shows that in the domains of the quality of life score, the deteriorated quality of life may last for 2 years and even longer. But what matters is not only the quality of life and pain. Why is it that I showed you a patient with chronic back pain and changed posture that sees the doctor after a long time? This is wrong. And the wrong thing about it is we need to diagnose the fractures as soon as possible, because the vertebral fractures are not only worsening the quality of life, they are increasing the risk of next fractures. And the earlier we diagnose, the earlier we treat, the better it is to prevent the subsequent fractures. There are several reasons for it. The patient, for example, may have already had previous fractures. Fractures, because of the limited motion, are then leading to further loss of bone mass. Very often there's a risk of falling. In vertebral fractures, there is a kyphosis that causes the weakness of muscles. And all this leads to the risk of further fractures. And importantly, this risk of fractures is time dependent from the last fracture. If the fracture was recent, then the risk of next coming fractures will increase multifold. This is shown in the upper curve. Below, you can see the curve of the risk of fracture in population. So then refracture risk is slightly going down over time, but it's still high. But the risk of next fracture is especially high within the 2 years. So we have to diagnose as early as possible. On the next diagram, you see that the risk is specifically high in vertebral fractures. How are we going to examine the patient? We know that the physicians do not have time, 15, 20 minutes per patient. And I liked very much a study that I want to share with you. There were studied patients with compressive fractures of vertebra. I have to tell you about this study, though my time is limited. We knew which vertebra is fractured. All the patients had MRI done. So 2 investigators were seeing the patients, well-known physicians were doing the palpation of vertebra, and when there was a pain, they were putting it in a circle. When they were doing palpation, then it was marked as a circle. Circle meant the patient complained. So the conclusions of the researchers were the following. Localization of pain that the patient indicated was often mismatching with the fracture of vertebra, very bad matching. The patient was complaining on one place and the fracture was in a different place. The pain of paravertebral palpation points was only in 27% of the patients, but only half of them had the matching of localization of pain and fracture. My conclusion is we don't have to necessarily do the palpation of vertebra. This is one of the specific symptoms. So as for the spinous process of vertebra, it is matching with the palpation. Change of posture, it's the reduction of height. If it was reduced by 4 centimeters as compared with the height at the age of 25, then MRI is a must. Reduction of distance between the ribs and also iliac bones. If this distance is 0, then a fracture of vertebra will most probably be seen on the X-ray. Densitometry is not always helpful. This is another patient. Let me bring you an example. A patient has a vertebral fracture, after a while one more, and densitometry shows -1, 2, as if there's no osteoporosis, but there is a severe osteoporosis. The patient has clinical manifestations and pain, and of course she has the fracture. If we're looking at densitometry only and we don't treat, we will worsen the life of our patients. They will suffer from pain, they will have subsequent fractures. Here is a clinical example. This is densitogram of a patient, 2 graphs above, -2.5 in a patient's vertebra. The patient didn't have any treatment. She comes in 5 years. T criteria is -1.8, as if she's better. But in fact, she came because the pain got worse. There was a compression of vertebra that is falsely reducing the pain sensation. But this is a false assumption in osteoporotic diagnosis. Below, the patient has a fracture of the proximal thigh part or bilateral. But we can see degenerative changes there. This is osteoporosis for sure, without densitometry. So what matters really much is X-ray. X-ray shows the deformation of vertebra, convection, knife-shaped convection, lateral deformation of the vertebra. This is another study that proves on the clinical examples what I said above. There was a big selection of patients, almost 2,000 candidates, 50 years and above. All of them had vertebral fracture, 70%, 20% had osteopenia, 9% were normal in densitometry, but all of them had severe osteoporosis. Lab tests. I'm not going to speak about it because we will have a presentation on it, but lab tests are a must. This is the minimum therapeutic biochemistry of blood and urine is a must. As for the back pain and further strategy, this is another article that shows that the back pain may not go away soon, and in these patients it might be chronic, so we should be ready for it. The pain goes away within the first 6 weeks and then it stays and goes away slowly. The patient should be ready for it, so we advise a corset, some regimen, and painkillers for a certain period of time. There were so many overviews on treatment. Let's take an overview 20 years ago and say in 2017, they are pretty much the same: painkilling, pathogenetic treatment, and non-pharmacological methods. If the pain is acute, then in fresh fractures or amplified pain, we recommend a regimen that helps the patients to avoid a long immobilization. In the first days, the patient may be in a reclining position, but every 2-3 hours, he should get up in a corset. And if the pain is stronger in walking position, then they have to lie down. So this is an intermittent mode. Long-term immobilization is harmful. As for the pain, adequate painkilling is required. There's an example of an article where various methods were used and regression in 9 weeks in a patient with lumbar vertebral fracture was obvious. Orthesis is helpful. There are various modifications. They reduce the pain. They unload the vertebra, improve the posture. The overview shows that there is no proof that orthesis leads to the weak back muscles, but we need to combine them with physical exercise. The risk of reduction of fractures, it's good to have olendronic acid, and you can see the reduction. Stronger drugs are denosumab and alendronic acid. Teriparatide is a very strong drug. It improves osteogenesis. Denosumab reduces the bone resorption. A few words about the algorithm we developed to help the GPs. When there's a moderate risk, we administer tablets. On the clinical example, we don't speak about it because we have a more severe case. If there's a high risk of fracture of thighs or vertebra, we need to administer more serious drugs. Parenteral bisphosphonates such as zoledronic acid, denosumab, and if it's not efficient, then teriparatide, like a second-line therapy. And the patient must be trained how to move things around, how to work in the garden. These are very simple pictures, pictograms, but we need to educate the patients, explain how to behave to avoid new fractures. Referring to this patient, the diagnosis is obvious. We may do densitometry, but this is not relevant for the therapy. We diagnose severe osteoporosis, scaphatic deformation of thoracic part, painkillers upon need, corset, physical exercise therapeutic, calcium, and D vitamin drugs, and zoledronic acid or denosumab. For example, I selected zoledronic acid. The patient was naive to treatment. If we don't know the status on vitamin D, then before giving strong therapeutic drugs, we give an elevated dose of vitamin D, for example, 10 drops per day during 10 days. Thank you for your attention. I'll be happy to take your questions. Lyudmila Petrovna, thank you so much. You were really concise and fast. We still have some time left and we can discuss. Please tell me. We don't have questions in chat, but I have a question to you. Please tell me. Well, most probably the GPs are listening to you, especially those who are older, when compression fractures of vertebra were treated by immobilization and long period, and when they were concerned to treat with physical exercise because the vertebral load may lead to further deterioration and new compressive fractures. So how to keep the balance between not staying immobile for a long time and not losing the bone because of immobilization, and how to start the physical activity. Are there any rules, recommendations to avoid deteriorating the vertebra? Thank you for your question, Olga Mikhailovna. All the exercises begin without vertebral movements, by hands, by feet. And a very important thing is the isometric exercise that is done without movement. The patient cannot be inclined, rotated. They don't need to have axial load, but the muscles must work. So when the patient is in a reclined position, if he's on the back, then a pillow or a towel rolled under the back. We try to put something under the lumbar part of vertebra, and then the tension of muscles for 5 seconds, 8 seconds, 10 seconds, and the same period of relaxation, repeat several times. This can be done several times during the day, starting from isometric exercise. First 3 months, the exercise without any movement of vertebra in a corset, but we do work with the muscle. Thank you so much. Please tell me at which stage can we start physical exercise after an acute episode of compressive fracture? In a reclined position, you can start the exercise on the next day. Start moving your feet and your hands. The exercise shouldn't increase the back pain. This is possible. We encountered this in rheumatology as well.
Меня слышат сейчас?
Доктора слышат?
Скажите, пожалуйста, нет, вот мы не в эфире.
Женя, доктора слышат? Тебя сейчас не слышно. Здесь нет. Да не слышно тебя здесь, Жень. Сейчас мы все подготовим, пожалуйста, и скажем, когда можно продолжить. Хорошо?
Так, сейчас меня слышно. Сейчас быстренько, буквально минутка, полторы, и опять же по команде выйдем обратно.
Что это вы так работаете?
Просим прощения. А это вот непонятно, какая-то техническая неполадка, сейчас будем разбираться. Ну, только сначала вас запустим.
Да.
Я не договорила, если будут вопросы, потом отвечу.
Хорошо.
Так, переводчик у нас...
Тамара.
Я думаю, что все-таки Людмила Петровна дать возможность закончить надо будет ответ на вопрос, на буквально минутку.
Давайте.
Да, Татьяна Леонидовна?
Да, конечно, Ольга Михайловна.
У нас есть время.
На втором зуме ее нету?
Тут один зум.
Даже если повисит ваша презентация, Людмила Петровна может ответить на свой вопрос.
Там вопрос, какие упражнения можно моя презентация видна только вам, она не выведена на экран.
Коллеги, это Тамара, назначьте, пожалуйста. Да, спасибо, все вижу. Спасибо. Thank you so much. Apologies, dear colleagues. We had technical problems. We have renewed the symposium. Lyudmila Petrovna Yevtigneva was taking a question about physical exercise in case of vertebral compressive fractures. Let's give her the chance to finish her answer, and then we will go to the next presentation, please. So I have already mentioned, let me repeat that axial load, twisting, rotating a vertebra is harmful. And there's chronic pain and acute pain. An acute pain will not allow the patient to move actively. He will be self-restricted. The load, what I mentioned, is harmful because the vertebrae are fragile. But if the pain doesn't allow to expand the range of motions and the patient prefers to lie down because of the pain, in any case, he should begin the movements of his extremities and shoulders. If it's hard to finish the exercise, the isometric exercise can be done just to do the tension and relaxation of hands and feet. A person is lying on a bag, is trying to exercise his hands and feet, and then relaxation. If there is no back pain, then a more active exercise is recommended. But again, no rotation, no bending of vertebra, of spinal column. If it's an acute pain, the exercise can be done in a corset by avoiding the risky exercise. As the frequency and duration of exercise are gradually increased, the muscular corset must be trained. Thank you very much for your depletive answer. We go to the next presentation, and I give the floor to Dr. Tatiana Karonova. Dear Olga Mikhailovna, dear colleagues, allow me to share the information that's really topical today, not only in the management of osteoporotic patients. That's why we called it deficit of vitamin D in osteoporosis, and not only. I'm not going to talk about metabolism of vitamin D. I hope you know it very well. I will only say that vitamin D is a very indirect one. In fact, we are dealing with a hormone that has specific receptors in the immune cell system as well. So today, in the event of pandemic, vitamin D is acting as an immune modulator, and that's why we include it in the therapy of patients, including the ones with COVID. Today, in Russia, there are lots of clinical guidelines on the prevention and treatment of vitamin D deficit. And these are the guidelines of Russian Osteoporosis Association, Endocrinology Association, Pediatrics, and the most recent guidelines are from several associations of gynecologists. Of course, today we are interested in a more advanced age. And we're saying that in all the guidelines until today, it is stated that the preventive doses are the polycalciferol, erdocalciferol in the dosage not more than 1,000 IU daily. But this is the level that should be sustained by an initially normal vitamin D level. The guidelines of gynecologists supported by the Russian associations witness to the fact that even during pregnancy, we may use 4,000 to 6,000 international units per day for a short period of time. Despite the fact that over the last 5 years, so many guidelines were published in Russia, according to the recent study conducted last year, the deficit of vitamin D is encountered in 80% of cases. And as you can see on the map, it is typical not only for the northern regions, which may seem natural, but also the southern regions where the percentage of deficit is quite high. The study initiated by the Almazov Center in cooperation with Helix Laboratory all over Russia showed that in 8 regions of Russia, there's a high rate of vitamin D deficit. It is less represented among the age group under 18 and more typical for 75 plus. And we're talking about this population with typical osteoporosis. It is very well known that large doses of vitamin D for the prevention of osteoporosis are not used. And as a combined therapy, it is enough to use the doses that comply with 800 international units, 1,000, 1,200, sometimes 2,000, but not more. Of course, we keep in mind that the therapy is not only to prevent vitamin D, but also it is a complex treatment with anti-osteoporotic therapy, and sustaining the level of vitamin D level above 75 will give us an optimal response to medication therapy. The deficit of vitamin D may also lead to hypocalcemia. And we're talking a lot about it. I'd like to draw your attention and say that the use of intravenous bisphosphonates, and Lyudmila Petrovna showed you the clinical case, zoledronic acid is of use. Let's keep in mind that there's a post-dose reaction on IV bisphosphonates, and vitamin D can be helpful in reducing the post-dosage reaction risk. This is another set of data, though it's not new. You can see that mega doses today are being used, 200, 300,000 international units to prevent and to support. Although the vitamin D level is growing at the same rate, the variability of this parameter among elderly patients is better when it's taken daily. Also, subcutaneous or perioral modes, when compared, show that perioral is more effective. So please note that probably for elderly patients, perioral daily regimen is optimal for the prevention and treatment. As an endocrinologist, I'd like to draw your attention to the fact that we may use the reactive metabolites of vitamin D, but this is a narrow, small group of patients with high risk of falling. Calcitriol as a hormone may be used in combinatory therapy. They may be used with glucocorticoid medication treatment. However, the interest to vitamin D is not always caused by osteoporosis. Because of the lack of time, I cannot tell you about every study. Let me just scroll down the main things and speak in bullet points. Today, there are 3 large studies on the role of vitamin D in the prevention of cardiovascular events, malignancies, and there are sub-cohorts that have been studied for the non-traumatic fractures and fallings. Vital, VIDA study, and a study on the development of diabetes mellitus is D2D study. The vitamin D therapy in the dosage 2 to 4,000 international units didn't show any positive effect in either of the studies regarding the primary endpoints. This is the VIDA study. The group of the patients, though, that was studied, and the elderly patients initially got 200,000 international units per month. With subsequent shift to 6,000 units, they showed a high rate of fractures. So the scheme is not operational among this subgroup. Vital on cardiovascular and oncoprotection didn't show any positive outcome. And last week on the National Endocrine Congress, they raised the concern there's no effect, why to use it? The same is true for diabetes. If we administer vitamin D in 4,000 dosage among the patients with prediabetes, it will not reduce the risk of diabetes mellitus. However, the sub-analysis of these 3 large studies shows that a large number of patients that were initially included in the study had a normal level of vitamin D. And the experts highlight that vitamin D therapy is operational only when there's a deficit, and you shouldn't expect pleiotropic effect when initially there's a normal level of vitamin D. Interestingly enough, vitamin D very often is treated as an immune protector. And the studies on the reduction of acute respiratory infections with vitamin D therapy have been presented long time ago. And one of the meta-analysis of 2019 analyzed the data of 25 studies and showed that if the patients have initial severe deficit, vitamin D is a prevention and protection from respiratory disease. As we speak about COVID-19 and the effect of vitamin D deficit, we can match these clinical forms and say that we see some overlay in the damage of coagulopathic chain, and of course cardiovascular failures that are on one hand a risk factor, and on the other hand they are a consequence of coronavirus infection. As for the overlay point of the virus on the immune system and the effect of vitamin D, we may see that vitamin D develops in the immune cells as a hormone, and it elevates a lot of negative manifestations of coronavirus infection. And so it's of great interest for endocrinologists and immunologists as well. Let me speak in bullet points about the last 2 years of experience. The studies show that there are more clinical forms of coronavirus infection with vitamin D. Some other studies show that not only the lowest vitamin D level and the ultimate high vitamin D levels are associated with severe course of disease. This is the combination when the worst effect of coronavirus infection is manifested. I think you have surely encountered in the literature and in the presentations the guidelines about the high doses of vitamin D for the purposes of prevention and treatment. Vitamin D is one of the measures to treat coronavirus infection in Russia as well. However, please note the doses should be small, while the guidelines for quick saturation are saying that there should be a very high dosage and a quick administration. But please note, we're not talking about the treatment of osteoporosis. This is to treat coronavirus infection. It may seem that if there's a correlation, we should conduct interventive studies. And indeed, for those who are interested, please pay attention to a review of Cochrane Library. There's an overview that included 3 intervention studies in various countries, the use of calciferdiol, high doses polycalciferol, and their impact on coronavirus infection and the outcome. Of course, we are part of this challenge, and in 2020, with infectionists, we conducted a pilot study and defined the level of vitamin D in the COVID patients, and we showed that indeed severe deficit of vitamin D is associated with a worse outcome and mortal outcome. The results were published in the American Journal quite recently, and it got a feedback from our international colleagues, and they published the excerpts of our results on their websites. Indeed, the severe deficit of vitamin D, 10, 11 nanograms per milliliter, is a cutting point which may play a bad role in the course of coronavirus disease. On the other hand, we understand that the focus is on the sick patients, and very often we disregard ourselves and the colleagues in the red zone. So we conducted a study that was then published on the Clinical Trials School website, and we will publish them soon. When the colleagues, the doctors who work in the red zone in the second wave, we recommended them different doses of vitamin D, and not just randomly. We recommended 50,000 international units once a week, then twice a week, subsequent shift to 5,000, and preventive doses of 2,000 international units. We included 28 colleagues. The lion's share were doctors and nurses, 15% of nurses. So we found out that the baseline level of vitamin D among the persons who are well aware of the problem shows that 88% of nurses had a severe deficit, 46 and 53% of the vitamin D deficit among doctors and nurses, plus deficit. I would say they pretty much had the same rate of deficit. The high dosage vitamin D therapy in 2 weeks' time led to the elevation of vitamin D to the norm, and it was maintained during 3 months. However, the preventive doses as well among healthy subjects also led to the increase of vitamin D in 3 months, but we didn't see a clear correlation of high dosages and prevention and absence of COVID-19 infection. However, we found out that the healthcare specialists who got high doses of vitamin D did have coronavirus infection. However, they either tolerated it lightly or with no symptoms. As for the patients, there's a protocol that is still incompleted. I will simply say that administering high doses of vitamin D, 100,000 international units during 2 weeks during hospitalization, gives a yield of concentration of vitamin D plus 40%, although it still doesn't reach a normal level. In a situation when you don't treat the patient and you don't add vitamin D to the therapy, the initially low level will fall in 10 days. We may define the impact of the coronavirus infection on it, but these are either concomitant processes or the vitamin D therapy is really reasonable. It will be even more reasonable if we achieve a concentration of vitamin D 40 and above nanogram per milliliter. This is an information for further reflections. So I'd like to wish you good health and take care. Thank you, Olga Mikhailovna. Tatiana Leonidovna, thank you so much for a very interesting presentation. You know, of course, so much attention to vitamin D recently because of the pandemic, but I'd like to say there's a very interesting article published this year in 2021 in Metabolism Journal, and it makes us take a different approach on the problem of correlation between vitamin D deficit and some respiratory diseases, including COVID. Interestingly enough, in their work, they made an experiment, and the young healthy men had a disease induced by polysaccharides, and they showed that the acute inflammation lasted during 3 hours, and during these 3 hours, they had elevated pro-inflammatory interleukins, and in parallel to this, the concentration of 25-OHD in blood went down. And then the cytokines went down and the concentration of vitamin D went down. This was a reverse cause and consequence correlation. It's not the deficit of vitamin D that leads to inflammation. It's just in general, during inflammation, the concentration of vitamin D is rapidly going down. Can you comment? Thank you very much, Olga Mikhailovna. showed it in the last graph that vitamin D therapy is increasing the concentration, but with severe course of disease or moderately severe course of COVID, show that the severity of infection is definitely correlated with the changing mass cytokine status, but most probably the change is happening because of the alpha hydroxylase activity. We're defining not the finite form of vitamin D, but some of its predecessive resources. There's a cause and consequence link, and we are actively researching it now because vitamin D can not be a sole reason, and you can't assume that by administering super high doses of vitamin D you will manage. Of course, masks are helpful, and any other anti-epidemic events, not only vitamin D. Thank you so much. I think we will discuss this interesting question many more times. And now, dear colleagues, I'd like to go to my presentation and talk about something that Ludmila Petrovna mentioned when she was talking about vertebral fractures. Let's talk about differential diagnostics of osteoporosis with other metabolic diseases of skeleton. We know what osteoporosis is, we can diagnose it, and we know that osteoporosis is about fragile bones, elevated risk of fractures, and this disease is manifested through specific fractures. Densitometry shows a reduction of mass or density of bone. But in my presentation, I'd like to draw your attention to the fact that the low energy fractures and low mineral density of bones may be indicative to other diseases. And if all the patients who have fractures and low mineral density are diagnosed osteoporosis, then we will be mistaken. We will not help the patient, and in some cases, we may even harm the patient. So it's very important. The density of the bone shows how mineralized the bone is. It's the mineral density. However, this is a reduced density. It doesn't show the reason. And this means that the bone density cannot show the differences between osteoporosis and other bone diseases. Of course, osteoporosis is the most frequent metabolic disease and the most frequent reason for the reduction of mineral density, but this is not the only reason. So when we see fractures in small trauma, the first thing that comes to mind, we think of osteoporosis. But keep in mind that there are some, let's say, private or secondary reasons, secondary osteoporotic reasons that shouldn't be disregarded. And last but not least, there's a very thin line leading to rare and even exceptionally rare secondary diseases that have to be diagnosed as well or timely suspected. You should at least figure out that this is a wrong kind of osteoporosis and something might be wrong here. Let's first of all speak about secondary osteoporosis. The most frequent reasons of secondary osteoporosis are illustrated on this slide. And the next slide, however, there are lots of them. And these bullet points include lots of groups of diseases, diseases of endocrine system, and these include Itzenka-Cushing syndrome, thyreotoxicosis, hyperthyreosis, diabetes. These are all the reasons of secondary osteoporosis. Among rheumatic diseases, we mean, first of all, inflammatory rheumatic diseases. There's a big group of GIS diseases, either the symptoms of malabsorption, chronic bowel disease, liver disease such as cirrhosis. And then there's one of the big reasons, this is the CKD, COPD, kidney disease, renal disease, blood genetic blood diseases. And please note, those who are dealing with the transplantation of organs, this is a procedure that underpins a lifetime treatment. All these are really important risk factors for the development of osteoporosis, in particular glucocorticoids. There are some other drugs, psychotropic drugs, and heparin taken long-term. Of course, all these factors are urging us to collect the history of disease, not to omit the diseases. But let's try to take a look at a very interesting variant that's rarely encountered in differential diagnostics. This clinical case is about a relatively young man who was admitted in a rheumatological hospital with regular, severe vertebral pain, pelvic pain, and he had generalist pain in the extremities that made it hard for him to walk. 3 years ago, the patient jumped from a truck and he had the fracture of both iliac bones. And after that, all the above mentioned pains emerged. Because of these pains, he lost his capacity to work. He is regularly taking the MPVPs and even Tramal sometimes. What we know about this man is he's an alcoholic. He was abusing alcohol for a long time, but then he quit. He doesn't use it for several years, but he's still an intense smoker, 25 years of smoking, 20, 30 cigarettes per day. And an interesting fact, his father died from melanoma, and the patient got scared. They explained to him that melanoma is from sun rays. He was so scared that he started avoiding insulation. And even in the sunny days, he was walking on the shady side of the street. When we examined him, he saw that he was moderately severe. He was hardly walking and he had to lean. He was quite thin. He had stiffness in all parts of vertebra, diffusory atrophy of muscles and extremities, pain during palpation in all rib and thoracic parts. And the doctors even suspected the ankylosing spondylitis. When the patient had densitometry made, let me remind you that he's below 50 years old. So by densitometry, we used the Z criteria that matches the mineral density with his age norm. And we saw that he has minus 4.8 of standard deviation. Thus, together with the history of disease and low energy fractures of iliac bones, the patient had a very low mineral density of bone. Moreover, during X-ray of pelvic bones, the diffusory osteoporosis has been described by an X-ray specialist. And of course, if we don't think and do additional examination and the lab tests, the first thing that comes to your mind is this young person has an osteoporosis, but he's a male, quite young. We need to think of the reason. And he had a varus deformation of both thighs, and he had the narrowing of the joints in the lumbar iliac joints. So we had to figure out what kind of osteoporosis this patient has. Let's take a look at the lab data. The only thing is the CRP in norm. And then we see that alkaline phosphatase is 987 units per liter, 8-9 times higher than the norm. Then we look at calcium. Expressed hypocalcemia, parathyroid hormone, hypoparathyreosis, and vitamin D in blood he had an extreme deficit of vitamin D. Remember, he was avoiding sunshine for many, many years. Add to this that the alcoholics have enteropathy and malabsorption of vitamin D is possible. So the lab tests showed very interesting results that are very untypical for osteoporosis. Let me highlight that in osteoporosis, all these parameters are normal except for the vitamin D deficit that is typical. So these kind of lab test results can be observed among patients with osteomalacia. Osteomalacia is diagnosed in this patient. Osteomalacia, what is it? As different from osteoporosis, when the bone mass is going away, here the organic matrix is preserved. You see the mass is there, but it is poorly mineralized. And the amount of calcium per unit of bone mass is reduced, and you can see it on densitometry. The bone becomes flexible and soft. Osteomalacia among children is called rachitis, as we know. Well, first of all, the most frequent version of osteomalacia happens because of calcium deficit, and it's called calcipenic because of vitamin D deficit, or its metabolites are in small amount. And the second more rare case is the deficit of phosphorus because of tubulopathy, which leads to the elevation of phosphorus extraction in the kidneys. We can see an apparent deficit of calcium and vitamin D here. These patients have demineralization of skeleton, which normally affects the spinal column, pelvic bones, and lower extremities. And we see that in this patient, we have low mineral density in the spinal column. He broke his pelvic, and the femoral bones are undergoing varus deformation. They became too soft over this time. Clinically, it is manifested, osteomalacia is manifested by generalized pain, muscular weakness that doesn't allow the patient to walk, and sensory neuropathy is possible. This is not my patient on the picture, but he looks very similar. He was moving in the same way, very similar to the man I was talking about. Lab test shows the elevated level of alkaline phosphatase and reduction of calcium level or phosphates in plasma later on. And phosphorus has to be examined not to omit this disease of osteomalacia. We can see apparent X-ray signs, the so-called loser zones on the upper surface of femoral bone. You can see an incomplete fracture, a very typical one for this disease. Deformation of pelvic bones that looks like a heart of shapes, and multiple foot bone fracture. Let me remind you of the diagnostic criteria of this disease. There have been, interestingly enough, developed by the Japanese Society of Endocrinology. It's hyperphosphatemia or hypocalcemia. Our patient had hypocalcemia, elevated alkaline phosphatase, which the patient had clinical symptoms, muscular pain and pain in bones, low mineral density, and multiple pathologies in scintigraphy of bones. We didn't do any scintigraphy, or loser zones in X-ray. Well, in fact, we didn't see the loser zones in this patient. We couldn't visualize them. And we didn't want to overload him with radial load, so we didn't continue the examination. So we diagnosed osteomalacia in this patient. We administered simple native vitamin D. At the start, we gave alpha-calcidol to elevate the level of calcium in blood. And in calcipenic osteomalacia, it is possible to have a complete healing from all symptoms because the reason is deficit of vitamin D, and it was eliminated let's try to figure out the elevated alkaline phosphatase. It's a very simple and cheap way. Any laboratory can do this test. So this parameter is helpful to see the health of the patient, but there's a physiological elevation of phosphatase level among children and during pregnancy. In bone diseases, it's very typical for hyperparathyreosis, for budget bone disease, and during renal dystrophia. And most frequently, before you hear these reflections on the bone diseases, you use this alkaline phosphatase for the diagnosis of hepatitis and liver cirrhosis. Thing is, our laboratories are looking at the general alkaline phosphatase, and they have some isoenzymes. One of them is a bone alkaline phosphatase. This is a very expensive method. So when we order this method, we need to understand that we see the elevation, which is caused by bone pathology as well. So we simply need to examine the patient furthermore. And since I've presented the clinical case of a young man, I want to highlight specifically that as different from women whose 85% of entire osteoporosis is the so-called primary postmenopausal osteoporosis, and only 12% are the secondary reasons of osteoporosis. The men have a different situation. Of course, first of all, among men, the highest rate is secondary osteoporosis with alcoholism, smoking, with COPD, glucocorticosteroids, hypocanadin, 45%, and 15–20% are some other reasons of secondary osteoporosis. And only when we can't define and detect these reasons, we diagnose primary or idiopathic osteoporosis among men. It's a third of the cases, but always in further examination, we continue and try to find the reasons for osteoporosis in this man. So we did this attempt to figure out in this patient, and we found the reason of low energy fracture and low mineral density in the form of osteomalacia. I want to briefly show you several slides of a study that examines the reasons of secondary osteoporosis among men. And in this large group examined by US scientists, number one in frequency was COPD, then glucocorticoids, hypogonadism, chronic CKD, so on and so forth. In the end is AP, transplantation, etc. So this is an example of what are the most frequent diagnosed diseases in these patients. From this study, I want to show you one more table where the patients with primary osteoporosis were taken when the doctor simply diagnosed primary osteoporosis, and the patients with secondary found the reason. And so when all these patients with primary and secondary started to take additional lab tests, so they found out that the primary osteoporosis was under-investigated. In a third of the cases, they detected low level of testosterone. It's a hypokinetic osteoporosis, deficits of vitamin D, almost the same as during secondary. They saw the elevation of hormone level, hypocalcemia was more frequent, hypophosphatemia, anemia, hypercalciuria, and reduction of GFR rate. And in this way, men and women, but especially men, have to be examined thoroughly for secondary osteoporosis. In our national clinical guidelines, this is very clearly described. And it is described what lab diagnostic research has to be done as we diagnose osteoporosis. Number one, it's the clinical blood tests to exclude multiple myeloma, oncology, rheumatic, and other pathologies. a study of biochemical parameters, total calcium, creatinine with GFR calculation, non-organic phosphorus, alkaline phosphatase, glucose. All the patients with a primary diagnosed osteoporosis have to undergo this. This table may help you in your subsequent work. Look at the level of calcium and the alkaline phosphatase. Please note that in osteoporosis, this level is normal, and only the deviations make us suspect osteomalacia, primary hyperparathyreosis, or metastasis of bone malignancies. The subsequent stages upon the doctor's consideration, this is more about hormones, stereotropic, T4, total testosterone among men and gonadotropin. And then we have a broader range when a broader search begins. From liver function, celiakia, it has to be excluded, so on and so forth. Recently, I was examining a young man. There was no other reason for his osteoporosis, only HIV. And for HIV, he gets specific treatment. It has been proven as a risk factor of osteoporosis. Thus, the secondary reasons are quite numerous. And of course, we need to keep them in mind. To conclude, I want to say that the reason for the low mineral density of bones can be various, and there are lots of diseases. So differential diagnosis is an important constituent part of managing patients with osteoporosis or suspicion. Thank you so much for your attention. I would like to give the floor to my next co-presenter, Olga Yershova. We have very little time left. I would like to say to the speakers that in our chat we have questions. Please take a look at them, read them, and then you will probably select the questions that you want to take. Olga Borisovna, the floor is yours. Thank you very much, Olga Mikhailovna. And you had an important topic on the diagnostics, while I will tell you about refractures. Let me start from a clinical case. We had a female patient, 54 years old. She complained moderate pain in thoracic part of vertebra. The pain emerged 2 years ago. They were growing gradually. When she is reclined, it gets less. With menopause, everything is fine. 50 years old, body mass 56 kilos. It's not quite big, but again, within the possible limits. She doesn't smoke, rarely takes alcohol. She doesn't like milk products. We understand she might have problems with calcium. She's physically active. She works. She doesn't have the history of fractures, but she had a radial fracture in a typical place. A standard study was done, and the classical signs of osteochondrosis were diagnosed. But we also saw the anterior deformation of first and second degree of several thoracic and one lumbar vertebra. She had multiple fractures of vertebra. We did densitometry, and we confirmed osteoporosis in the lumbar part, -2 and 9, and she had osteopenia. In this way, the data that we got, the fractures and the fractures of her bones, multiple ones, and the fracture of forearm, make us diagnose a severe postmenopausal osteoporosis with bone fracture. The patient was examined and she was appointed treatment, alendronate 70 mg per week and calcium 1000 plus calciferol 800 international units. Was this strategy accurate or not? Let's think about it. The persons with low energy fracture, they get double the times less fractures. The patients, 50% of the patients who with refractures tell us that they had fractures before. Among Russian patients, refractures were prevalent in half of the number of women and 40% of men. With every new fracture, the risk of fracture is increasing. And so this is a very important thing. The more the number of fractures is, the higher the risk is. With every new osteoporotic fracture, physical, psychological changes are increasing, biomechanics and motor function are changing, the quality of life is changing for worse, but of course the risk of death is increasing too. And meanwhile, 80% of the patients with low energy fractures were never treated from osteoporosis and never tried to reduce the risk of falling. Interestingly, the frequency of anti-osteoporotic drugs is only in 20% of cases and in 27% of fractures of radial bone. What to do? Ludmila Petrovna already mentioned that there's an approach when we identify an individual risk of a particular patient. So the patients with moderate risk are following one strategy. Patients with high risk follow a different strategy. We speak about the patients with high risk of fracture now. What does it mean? The patient either has a fracture of vertebra or femoral bone, or the patient has other fractures, for example, and the criteria should be below -2.5 and the 10-year risk of fractures more than 30. Our patient had both. The forearm fracture and densitometry was below -2.5 standard deviation, and most importantly, she has a fracture of vertebra. And of course, she is definitely a patient with high risk of fracture. What do we do in this case? In this case, we should start not from perioral drugs, but parenteral, bisphosphonate, zoledronic acid, or denosumab. And of course, the teriparatide that was already mentioned as an anabolic drug, but the special thing about it is it's used for only 2 years regularly, and then one must go to anti-resorptive drugs. We will discuss it now. If we go back to our patient, she had a milder pain, but in T criteria, she had a negative dynamic. She didn't go to X-ray. It's fair enough to mention that the patient often forgot to take the tablet of bisphosphonate, and her compliance during 12 months was 65% only. And also she was breaking the rules, and she was not always taking the drug in the morning after fasting. What do we need to do, and what are the reasons for actions? Of course, in severe osteoporosis and high risk of refracture, one should start from bisphosphonates that are taken parenterally. Why? Because alendronate and risdiplam, the efficacy of their use is 10 times higher than in the drugs that are taken periorally. Evandronic acid that is used once per 3 months shows great efficacy in reducing the risk of vertebral fractures by 62%. It's very convenient to use it because it's once IV in 3 months, well tolerated, almost no changes of acute phases. It is simply done at the examination. The only limitation, evandronic acid, the only limitation is the postmenopausal osteoporosis. There are no other indications for this drug. As for zoledronic acid, at the moment, it's a highly efficient drug. It's used once per year with a high injectable concentration. The drug is embedded in bones and it stays there for long, and it has a very good effect. Even on the cumulative risk of the femoral bone fracture, it gives a 41% reduction. It's a great result for a femoral bone. The study also showed that zoledronic acid reduces mortality by almost 30%, and not only by reducing the risk of fracture, all in all, zoledronic acid reduces the risk of vertebral fracture, and 3 years after, the effect is still there. We can use zoledronic acid maximum 6 years non-stop. The studies were carried out there's no data for longer term follow-up, so the maximum period is 6 years. The main side effects are acute phase reactions and atypic femoral fractures and acute necrosis of mandibula. Acute phase reactions are normally observed in zoledronic acid. It's important to keep in mind that if the patient earlier took perioral bisphosphonate, he will not have these reactions. Before we treat the patient, we need to look at the level of vitamin D in blood, not saying of creatinine clearance, calcium. It was shown that the patients with vitamin D deficit are poorly tolerating the infusion. As for atypical fractures, of course, for IV bisphosphonates, this variant is something we should always keep in mind, although the frequency is very low. But please note that this is a very interesting fracture that doesn't occur instantaneously. At first, the patient feels pain in femoral part in his foot, and then in 2-3 weeks, he will have a fracture. So if we do a radial X-ray study at the moment of complaint of a patient, and if we do the gluing timely, then we will not have a complete fracture. Nevertheless, as we are playing with a balance of benefit versus risk, when we take bisphosphonate during 3 years, it should be 1,200. As for osteonecrosis of mandibula, this mainly occurs among the patients who use bisphosphonates in treating cancer, myeloma, breast cancer. This is a rare phenomenon, but once again, keeping in mind that this problem is possible, we need to see if the patient is going to do any interventions in oral cavity. If yes, then it's better to finish them and then do the treatment. Another drug is denosumab. It's a monoclonal human antibody. It's taken subcutaneously once per 6 months. It has all the classical indications of classical osteoporosis. It's used in breast cancer and prostatic cancer. It showed efficacy the risk of femoral fractures is going down. The study of the drug was carried out during 10 years, and all this time there was a low rate of fractures. Interestingly, this drug is always increasing the mineral density of bones during all 10 years of use. And importantly, it not only impacts the trabecular, but also the cortical bone mass. And it's an important aspect of the denosumab efficacy, as you know. A very nice level of AE. They are not encountered frequently, and there are not so many counterindications from denosumab. Hypersensitivity, we have to examine calcium before we study, and pregnancy and pediatric age are counterindications. This is the only drug that we can use among the patients with low creatinine clearance level. Interestingly enough, the action of this drug is reversible. As soon as the period of action is over, we should do the next injection in a month, and then we have a very good effect. In this way, if for some reason we are interrupting the denosumab therapy, we either stop it or we try to do something else. We need to understand that we can't simply do it. There was a study showing that if patients finish denosumab therapy and switch to another pathogenetic drug, for example, olendronate, they can avoid, or we can prevent the loss of mineral density. And bisphosphonate was used there as well, and it prevented the rapid change of markers. There's a rule here saying that if we try to stop treating with denosumab, then 6 months after stopping it, we have to administer bisphosphonates. If we're talking about zoledronic acid, it is recommended to make an extra break up to 65 days. There is another drug, teriparatide. It has a very good effect, recommended to the patients with low energy fractures or fresh fractures, including the ones with anti-resorptive therapy. In this case, for non-efficacy of see, after teriparatide, when you go to denosumab, there's an amazing effect. And today we more and more hear that in severe osteoporosis with a fracture, the anabolics are very good. And the best effect is when we combine denosumab and teriparatide. The same was for the femoral neck. It should be kept in mind that in any treatment, calcium and vitamin D have to be administered. As for the breaks in treatment, you should clearly understand that the patients with high risk cannot interrupt the therapy. They can be changed to another therapy or group of drugs, but not interrupt because these are high-risk patients. What to do if a patient has a fresh fracture, and as soon as possible, we must start the treatment. In this case, we have clear indications showing that there is no negative impact on the healing of fractures in none of the above-mentioned drugs. But in IV bisphosphonates, it's recommended to wait for 2 weeks before the start and then start the treatment. Or wait 2 weeks and start it after the surgery of fracture. But there is an opinion that teriparatide may lead to the healing of vertebra, and it has a positive impact. this recommendation, this guideline in the instruction saying that for the prevention of subsequent fracture, the first infusion of a drug must be done 2 weeks after the surgery or the fracture. For denosumab, there is no evidence. It's acting quickly. It can be injected right after the fracture. Right after the injection, we can use denosumab teriparatide, administer vitamin D and calcium, and then 2 weeks later, IV bisphosphonate, perioral bisphosphonates. Of course, if there is no other chance, we may use them, but it's not so efficient and it's not so good in terms of the doctoral algorithm in severe osteoporosis. I want to highlight again that for an efficient prevention, we need to create the system of secondary prevention that's available in many countries of the world, in Russia as well, and they are designed to detect these patients, deploying this treatment, administering the therapy, and having the long-term adherence to therapy. Thank you for your attention. Thank you, Olga Borisovna. And thanks, among other things, for clarity. You've managed to convey a lot during short time, and you even mentioned the prevention of refractures. This is very important, and this is something they work on in many different regions of Russia. Dear colleagues, I'd like to say that we have questions today. Let's be concise. I'll briefly read the questions and please prepare to answer. Just say it in just a few words because we can't keep our audience long. First question to Lyudmila Yevsegneva. What is the strategy of medication treatment of osteoporosis among patients with FP? I think FP is atrial fibrillation. Oh yes, I saw this question and I thought this is atrial fibrillation. In fact, it was only zoledronic acid showing that AF was slightly higher than in placebo. It's 1.3%. But in terms of pathogenicity, it was not correlated. As for other drugs, there's no correlation with atrial fibrillation, and FDA doesn't see correlation, and it doesn't think there's a limitation in administering zoledronic acid among the patients with AF. It's not a contraindication. Thank you. Next question. Female patient, 71-year-old, getting therapy of aromatase inhibitors from January 2019. Denosumab preventively during 2 years, once per 6 months. In spring, as we controlled the level of vitamin D in blood, we saw 18. It's a deficit. At the moment, she's taking 2,500 units of vitamin D daily. Does she need to take calcium as well? Water from the well with a maximum level of calcium content. As for densitometry, she has osteopenia. Question to you, Tatiana. I think 2 questions here, whether we should increase vitamin D dose. I think either to change it or slightly elevate it to 4,000 or follow the standard scheme, 50,000 per week during 2 months and then shift to the maintenance dose. This is the first thing. Second thing, should she take calcium? Of course, we want to know the content of calcium in water. And we know that if the food calcium is 1,000 mg, then she can skip taking it. However, there's a question, calcium from the water from the well, not associated with albumin and other proteins. I think it's a debatable question. I cannot take it clearly until I know the total sum consumption of calcium of this patient, including the dairy products as well. Yes, yes. For vitamin D, I wanted to double check. In spring, the level of vitamin D was 18, and at the moment, she's taking 2,500. Maybe it makes sense to look at vitamin D level in blood and then think whether she should elevate the dose, yeah? You're right. If we're talking about spring this year and the patient either started taking this therapy, it depends also on how she spent her summer. I would control 25 OHD now and then make a decision. Thank you, Lyudmila Petrovna. Can you add something about water? I didn't find any evidence that the calcified water in the well can be equivalent to the calcium that we believe is useful for the body. Okay, we'll agree with Tatiana Leonidovna. It's better to look at the nutritious calcium. Can we administer denosumab if the patient already had the fracture of vertebra, or it's better to use zoledronic acid? Well, in fact, both zoledronic acid and denosumab can be administered. Both are highly efficient. Both have instructions, and if there are no limitations on the therapeutic dose, you can administer either of them. If we're talking about medical indications, both are possible. Thank you. Next question for Olga. The preventive administration of bisphosphonate to the women under 55 in case of surgical menopause. What do you think? I guess it was Tatiana Leonidovna to take this question. I personally believe that hormone substitutional therapy must be administered here, and if possible, an endocrinologist must make a decision, because from the perspective of prevention, there is an indication. But for that, half a dose is used. Secondly, there must be a strong reason to administer bisphosphonate for preventive purposes, because this is quite a serious drug, and we should follow the prevention in a correct way. So menopausal hormonal therapy, right? Okay, zoledronic acid among women above 55 with osteopenia for preventive purposes once every 18 months. We shouldn't be in a haste to administer bisphosphonate to the young women. You were talking about alpha-calcidol. Monotherapy and the complex of calcidol. Is it possible with denosumab and bisphosphonates? Thank you. Anti-alpha-calcidol is a second-line therapy, and so it can be used for the therapy of osteoporosis. As a monotherapy, it is hardly indicated, because the main absolute indication for alpha-calcidol is the hypoparathyreosis or hypocalcemia. Or these are patients with chronic kidney disease of 4th and 5th grade. In terms of osteoporosis, there is a relative indication. Usually it's all included in the complex therapy. Let me say that if we still administer these drugs, then we control calcium, and it's not a rapid increase. if you want to additionally monitor 25 OHD, believe me, it was initially low and it will remain initially low if you don't administer additionally polycalciferol. And the last question, although we are talking about osteoporosis, I want to ask Olga Borisovna a question. We're talking about aseptic necrosis of bones and microangiopathy of bones. Look at how diverse the complications are. Olga Borisovna? Should we administer bisphosphonates? Well, only in terms of reflections. I want to say that we don't know what was the nature of septic necrosis, idiopathic aseptic necrosis, lots of reflections, lots of works, lots of attempts to treat it. It happens on glucocorticoids, without them, among young, healthy people. I would say that this looks like post-COVID microangiopathy. I don't know why it's post-COVID specifically, but it's a kind of angiopathy. As for bisphosphonates, we need to know more about the patient, his age, his history, mineral density of bone. But to simply administer bisphosphonates for aseptic necrosis is something we don't have direct indications for. But we don't know anything about this patient, so it's hard to say. You know, I think this question was not asked by chance, because recently I hear a lot from the physicians and traumatologists. They often talk about bisphosphonates in aseptic necrosis as a proven situation with direct indications for bisphosphonates. I thank you for raising this question, and we need to say again that no official indications for bisphosphonates are there. And if you administer, it will be off-label. Yes, there are works that show that if we administer at the early stage of aseptic necrosis, we will slow down the bone resorption, which is very often manifested as the start of necrosis. However, these works haven't been elaborated on in the meta-analysis. So I think that some traumatologists are simply in a haste to give these guidelines, because we know that it's hard to administer drugs with off-label recommendations. This should be a well-grounded decision. Any comments? No. In this case, we will wrap up. Let me remind you, it was the symposium of the Russian Osteoporosis Association. We discussed very interesting, challenging issues. This was not for the beginners, I would say. I hope very much that you found this session useful. I wish you good health and every success. Thank you and goodbye. And of course, thank you so much to our speakers. Thank you.